सब फ्लो प्रोग्राम का यही रहेगा सर. मैं इंट्रोड्यूस करूंगा. आई विल जस्ट गिव a brief introduction of all of you, and then we'll hand over to you all, sir. Then this will be an extempo talk रहेगा, although there is no slide presentation. Your expert view on vildagliptin as such, and then followed by I will take you through one slide and then close with my word of thanks, sir. Yeah, we have, I think, Dr. Kapoor also joined in. I just saw him actually. Yeah. Mr. Amrish, have you connected to Dr. Kapoor?
Yes.
So
He is joining.
Yeah. He just joined in between. I just saw him actually. Then again suddenly, got disconnected.
Actually, he is trying to joining through mobile. That's why.
Oh,
Yeah.
I see. Yeah. Yes, doctor. Very good afternoon. Welcome, sir.
Anji, good afternoon.
Yes, Rakesh Upadhyay this side, sir.
Okay.
So we have all doctors on board, sir. We have Dr. Rajiv Gupta, Dr. Sumit Sethi, Dr. Ashutosh as well. And now Dr. Prem Kapoor has also logged in. So welcome you all, sir. Just if you allow me, can I just start the program, sir?
Yeah, please do that.
Yeah, thank you. Yeah, Mr. Amrish, can you just put it on for delegates?
Yeah. Give me next 1 minute.
Yeah, sure.
Yes, over to you.
Yeah, thank you. So on behalf of Wellcome Laboratories, India's fifth largest pharmaceutical company, I, Rakesh Upadhyay, welcome our eminent doctors who have joined us for today's panel discussion titled Views on Vildagliptin. At Elchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us navigate through the meeting, we have with us today Dr. Prem Kapoor, who will be our moderator for today's panel discussion. And I take this opportunity to welcome him for this program. Dr. Prem Kapoor, he is a graduate and postgraduate in the year 1982 in general medicine from Maulana Azad Medical College, New Delhi. Worked as a specialist grade 1 super time senior administrative grade in erstwhile Hamdard University Hospital, Jamia Hamdard, New Delhi for 25 years. He worked as a professor and head of Department of Medicine, Hamdard Institute of Medical Sciences and Research, Hamdard University. Over 30 publications in national and international journals, and has written many chapters in various books and monograms. Fellowship, he has Fellowship of Indian College of Physicians, Indian Academy of Medical Specialists, College of Chest Physicians of India. So with this, sir, I welcome you for this program on vildagliptin. Thank you for giving your valuable time, sir. And now I would also like to introduce our galaxy of panelists. We have Dr. Ashutosh Goel on board. He's a senior consultant, endocrinology and diabetes at Paras Hospital and Dr. Goel's Endocrine Clinic, Gurgaon. He has completed DNB Indo in April 2015 from Sir Gangaram Hospital, New Delhi, and participated as speaker and chairperson in more than 100 CMEs, webinar and conferences, and also participated in various research projects as principal investigator and like Landmark and IDMPS, etc., and various other research projects as well, and has many publications in national and international journals. So, with this, sir, I thank you very much for giving your valuable time, and I welcome you, sir, for this program.
Thank you.
Yeah, thank you. We have Dr. Rajiv Gupta. Dr. Rajiv Gupta is a senior consultant internal medicine practicing as a diabetologist expert from last 35 years. He is a graduate and postgraduate from MEMC and gold medalist, fellow ICP, senior consultant in Fortis Hospital, Shalimar Bagh, Delhi Heart and Lung Institute, and MD City Hospital. He has chaired many CMEs, prolific speaker in many CMEs. So I welcome you, sir. Thank you very much for coming to this program, sir. And then we have Dr. Sumit Sethi. Sumit Sethi is presently in Max Healthcare Saket. He is a senior consultant in Department of Internal Medicine. He is a specialist training skills like in IV cannulation, bone marrow aspiration and biopsy, pleural aspiration, pericardiocentesis, and also he has got a specialist in lumbar puncture, endotracheal intubation, bladder, yeah. Bladder catheter. Oh, right. Okay. So, and he's also into teaching experience as well. He has teaching guide for DNB students, has been part of many research and observational studies as well. So not taking much time now, I just take this opportunity to invite Dr. Prem Kapoor to set the context and start panel discussion. I just hand over to you, sir. Thank you very much. Sir, your mic is mute mode.
Yeah,
sir.
it is unmuted.
Yes.
Okay, thank you so much. Actually, this meeting has been arranged to discuss about the current status of one of the DPP-4 inhibitors, vildagliptin, in the current scenario. And as all of you know that even till today, ADA recommends metformin as a first line of therapeutic management when it comes to using a oral anti-diabetic drug. The only issue is who marries metformin. Means after metformin has been used to a maximum dose of 2 grams per day, and the blood sugar is still not controlled, which should be the second line of drug to be used. You see, that is the controversy, and we all of us have used DPP-4 inhibitors to a very efficacious manner, but still recently there have been a lot of changes. We have had the verified trial saying that you use early drug combination to prevent drug resistance and complications on long-term basis. And then this drug vildagliptin has also gone off patent, and hence the market scenario is also changed. You see, so all these things have made a difference. We are going to discuss about some very important issues as far as DPP-4 inhibitors in general and vildagliptin in specific is concerned, because there are issues with using these drugs in older population who are already prone to a lot of cardiovascular abnormalities. These drugs are used in combinations. So what combinations can be used, that needs to be discussed. And a very important aspect apart from cardiovascular safety and concern is the renal problem. See, patients with the renal disease who have diabetes mellitus, where does vildagliptin stand as of today? And then we're going to discuss about other gliptins vis-a-vis vildagliptin, whether to use vildagliptin or use other ones, what is the advantage of using vildagliptin. And of course, as I told you, since it has gone off patent, so we need to look at vildagliptin with a different angle now and see where do we place it in our armamentarium for treating diabetes mellitus. So with this background, I'll now request Dr. Ashutosh Goyal to start the proceedings. Dr. Goyal, please, can we have your expert comments on the role of DPP-4 inhibitors in general and vildagliptin in specific as far as anti-diabetic treatment is concerned? Dr. Ashutosh, please.
Sir, he got disconnected.
Okay, okay. Then can we request Dr. Rajiv Gupta, who is an old colleague of mine from Maulana Azad days? Can we ask him to give his expert comments on the role of DPP-4 inhibitors in general and vildagliptin in specific? Dr. Rajiv Gupta, please.
First of all, at the outset, I would like to thank Alcam and of course my old teacher and my guide and my inspiration for life, Prem Kapoor. I remember what happened between us for 5-6 years when we are together. So
Right.
you hold an inspirational model to me. Right.
Thank you, thank you.
Now, with this, I'd like to answer this question: the role of DPP-4 inhibitors. As a matter of fact, even today, all guidelines, including ADA, ESD, all recommend lifestyle modification followed by metformin as the first line of management for type 2 diabetes in general.
Okay.
Now, issue is at the outset, they would like to separate some patients who are very high risk patients of diabetes, particularly for those having established cardiovascular risk factors or patients who have a high risk factors for development of future cardiovascular events or patient of CKD. Now they are being swept aside and they have been offered different treatment. But a large majority of patients who do not have established cardiovascular disease or CKD or congestive heart failure are still eligible for treatment. Now treatment will be offered in the form of oral drugs. The issue is after metformin, as you very rightly said, what after metformin? Now we have a whole cocktail of drugs available on the shelf, and we can offer patient any drugs which offer advantage. Now, what can be the advantage? The drug which you want to choose has to be efficacious, has to be durable, and has to be relatively safe and without many side effects. Now, in this category of patient, it has to be cheap. It has to be given on a long-term basis, has to be cheap. Now, in this category of patient, after metformin, a safe drug, which is having virtually placebo, can be DPP-4 inhibitor. Now, DPP-4 inhibitors are relatively mild drug. You say that they reduce HbA1c by 0.4 to 0.6%, but if the starting HbA1c level is high, then they will cause more impressive fall in HbA1c up to the tune of 1%. Particularly in the Indian scenario where carbohydrate load on the diet is more, we expect a larger decline in HbA1c when we use DPP-4 inhibitors. Now, other drugs like sulfonylurea, pioglitazone, they all have their side effect. They are more potent, but they have side effect profile and they have different kind of side effect like hypoglycemia or weight gain. DPP-4 inhibitors do not cause much hypoglycemia, even along with metformin. They do not have the problem of weight gain. They are all weight neutral. And they all have shown established cardiovascular safety. So three things which are very important, will definitely put them in perspective, are these three things. And I think they can become an element of choice if you want to use it on a long-term basis. So I think that should be all, or should I elaborate further?
Okay. So, what's your take on vildagliptin versus other DPP-4 inhibitors?
Okay. Vildagliptin, as you know, we have sitagliptin, vildagliptin, saxagliptin, tinagliptin, and other one, there are a few more gliptins. So, alogliptin, all those gliptins available. And all of them are shown to have cardiovascular safety profile, including vildagliptin. The dedicated trial with vildagliptin has not been done, but all other trials and meta-analysis of whatever data is available also show that it is cardiovascular safe. So vildagliptin, besides cardiovascular safety, besides being a good DPP-4 inhibitor, it has shown to reduce day-to-day glycemic variability. If you do day-to-day excursions, I think postprandial variability is better controlled by vildagliptin as compared to other drugs. And as a matter of fact, now we talk of dysglycemia, particularly post-glycemic dysglycemia, which is now directly linked to cardiovascular outcomes. So from that angle, vildagliptin probably would score over others gliptins as far as glycemic variability is concerned. So this may be a different agent over other DPP-4 inhibitors in routine situations.
Correct. I think I'll concur with you. and the very fact that it has gone off patent and the cost of the drug has also reduced. And this is one of the two drugs that we have been using for a very long time. You see, we have been using Sita and Vildagliptin for a long time. The other drugs came along a little later. So we have good amount of experience with these two drugs, and with this drug being off patent now and the cost being going down, I think there is a prospect of using this drug more often than before. And we look forward to more trials of this drug as far as CV safety is concerned and the benefits are concerned using Vildagliptin. So if Dr. Ashutosh Goyal is now available online, can we request him to give his expert comments on the role of DPP-4 inhibitors and Vildagliptin?
Yes, sir. So definitely, yeah. So good evening, everyone. So a role of DPP-4, I would say, as a second line drug in addition to the metformin. So this we all would agree that we are using this drug for last almost more than a decade now, and we are seeing a good results after starting the DPP-4 in the form of HbA1c reduction. So we achieved the HbA1c reduction around 0.6%. As Dr. Saab told that if patient has an initial high HbA1c value, then HbA1c reduction could be on the decline could be on the more side. But I would like to add one point in this, that if patient is already on a high dose of sulfonylurea and patient HbA1c is in the range of 9 to 10, so we may not be even achieving the HbA1c reduction of 0.6%. So we have to see whether the patient is a treatment naive patient is only on metformin, then definitely HbA1c reduction would be much more. But if patient is already on high dose of sulfonylurea, patient is a long-term diabetic, in those patients, even achieving HbA1c reduction of 0.6% may be difficult. Because these are definitely efficacious drug, but not as efficacious as we can say as sulfonylureas or as an insulin. Secondly, if we say about the safety margin, so safety margin, we know that the DPP-4 inhibitors have almost no contraindication except if a patient has a history of pancreatitis or patient is having acute pancreatitis. In those patients, we usually avoid this DPP-4 inhibitor, although in elderly population, in CKD population, in I would say every type of diabetic patient, DPP-4 works well. So we are using this drug in every patient, and now during the COVID time, also during the online consultation, I would consider this to be as the safest drug. So this is the, I would say, like a second line drug. Now we have SGLT2 inhibitor, and we are using that drug also in some patients. Definitely those patients who are obese, those patients who have cardiac issues, references toward the SGLT2 inhibitor, but still we are giving DPP-4 inhibitor. And regarding the Vildagliptin, definitely we were using Vildagliptin previously also when it was costlier. Now the cost has been reduced, and we have increased the use of Vildagliptin. And definitely if we consider the Vildagliptin as compared to other sitagliptin or linagliptin, efficacy wise, almost both the drugs are same. All the drugs, DPP-4 inhibitors are same if we are using Vildagliptin in 50 milligram BD dosing. Secondly, the concern was regarding the CKD population that I think we will cover up in the next few questions. We will be discussing about the CKD. And now I would say previously we were not using Vildagliptin in CKD patients because I think we have similar drugs in the form of sitagliptin that would also be cost-wise, it is similar to the Vildagliptin, but now the Vildagliptin cost has been reduced. So we can now use this Vildagliptin in CKD patients also. So that's my take on this Vildagliptin. And I think over back to you, sir.
I think you very rightly pointed out that in the recent epidemic of COVID also, we have now papers saying that DPP-4 has a slight edge over other OHAs at least in treating patients during the COVID epidemic. Although insulin still remains the drug of choice for controlling high blood sugars in our patients of COVID who are on steroids and show a spike in their blood sugar levels. But out of OHAs, I think DPP-4 inhibitors seem to have slight edge over others. And the outcomes seem to be slightly better with DPP-4 inhibitors. I'll now request Dr. Sethi. Saurabh Sethi is online.
Good evening. Good evening, everybody. Everything has been said now, though I have few points to make on to. Yes, vildagliptin is a drug, which everyone is using now day in, day out because of its reduced cost also. And yeah, definitely when you talk about cardiac safety and benefit over other SGLT, other DPP4, it is the best when it is compared with even, sitagliptin 50 or 100. It has an edge over sitagliptin also. So it is definitely the drug of choice in today's scenario. When it comes to when it's come to COVID and COVID related complications and high sugars because of the steroids what we are giving, I definitely agree with both the panelists in some that yes, DPP4 can be added, but I also add DPP4 along with insulin, but because of late onset, the glycemic control over patients where we want a immediate control of sugars, so we happen to add insulin, but definitely DPP4 also helps us because these sugars will be on the higher side for next 2-3 weeks or 4 weeks where we are using high dose of steroid, and over a period of time a patient is diabetic, so needs to be controlled with DPP4 along with insulin and sulfonylurea. So that depends upon doctor to doctor. We are using very high dose of steroids, so we use all types of modalities like adding insulin, sulfonylureas or DPP4 because these sugars are not getting controlled for next 2 weeks or 3 weeks where we are using steroid for a long time. In even fibrosis patient where you using a low dose in steroids on those patients. Definitely it has an edge where we can use this patient in CKD patients also where you have mild to mild we can definitely use. Moderate to severe also we can reduce the dose and you can use this, except that in liver, active liver metabolic diseases and pancreatitis, where that is the only contraindication. We don't use vildagliptin, but otherwise all the other settings, even in old age patient, it has shown improvement because of low hypoglycemic events, and others definitely having a beneficial over other OHAs like sulfonylureas. And everything else is being said upon. It has, because of the cost also reducing now, we are happy to use in majority of our patients. More of our poor patients are also, we have been able to use this drug. So I think vildagliptin is right now is the drug of choice and flavor of the year where we can use vildagliptin in all the patients. Yes, vildagliptin out of all these DPP4 is slightly better because of the cost and other side effects. And I would want to add on to, I personally feel that yes, whenever you have your patients are on sulfonylurea plus metformin, DPP4 definitely does wonder. In patients with insulin, DPP4 adding on to DPP4 is also giving us a good results. And nowadays, when we are talking about, vildagliptin using in patients with SGLT, where it has it reduces the EGP. It has a synergistic effect if it is being used and as an adjoint with SGLT2 inhibitors. So if you use SGLT and DPP4 like vildagliptin, it it inhibits glucagon secretion and can it increases the EGP, which helps in case of SGLT where the increase in SGLT EGP in SGLT2, which affects the glucose lowering effect by approximately 50%. So with adding on to SGLT, I feel it has an edge over other OHAs where it, it has an synergistic effects to reduce HbA1c.
Right. Dr. Sethi, what is your take on a single dose vildagliptin per day?
I have started using single dose vildagliptin, and it has been giving. See, majority of my patients are not, where we have an HbA1c or a clinical life. We have combination of patient coming into where I have to use this with. With a combination of metformin or sulfonylureas. But yes, I am using this drug as a single dose also, where I'm using vildagliptin as 100 milligrams per day. So it, it has beneficial effect. If you talk about as a clinical trial also, it has shown in better when it is compared with 50 milligram of sitagliptin or 100 milligrams of sitagliptin also. It reduces the cardiac outcome. It improves the cardiac outcome also.
Correct. That is the dose that we were earlier using for our CKD patients.
CKD patients.
Taking a single dose 50 milligram because
50, where we can reduce my moderate to severe cases. Yes, absolutely right.
So I think there is consensus of opinion that vildagliptin holds its fort out of all the DPP-4 inhibitors, and in general also, we have all used DPP-4 inhibitors and we have found them to be very safe. And frankly speaking, I don't know if any of you have really seen a patient of, because malignancy is totally out, but acute pancreatitis also following DPP-4 inhibitors. I haven't seen a single patient of acute pancreatitis. Somebody who already has it may get aggravated or have more frequent attacks. That's a different situation altogether. But a fresh acute pancreatitis occurring with the DPP-4 inhibitors, at least I haven't seen any. If any of you have any experience, maybe you can share it with us.
Very, very, very rare. In my clinical practice of 14, 15 years now, I've seen only 2 patients. One was, someone had given a acute pancreatitis, which was precipitated by DPP-4, was given again a DPP-4 vildagliptin. And one more patient was a recurrent pancreatitis patient, otherwise also keep coming for, and was also given this DPP-4. So I have only 2-3 few patients of that. Yeah, definitely not in recent past where I've seen patient coming. Probably, diabetologists these days, they also know when there is patient having a history of pancreatitis, they don't start on DPP-4 or provided vilda. But otherwise, I haven't seen in my near recent future time. Yeah, when it started, yes, I definitely did see few of the patients, but not now.
Dr. Anil and Dr. Saurabh, you have any experience of seeing any patient of pancreatitis following initiation of treatment with one of the DPP-4 inhibitors?
Can I answer? I vaguely remember one patient where probably that was related to DP4 inhibitor. One case. I remember 35 years of practice. I can remember one case. But again, there was doubt whether it was a chronic pancreatitis precipitated by DP4 inhibitors or otherwise. That was difficult to say. So the patient do have long-standing vague pain in the abdomen, and that has not been diagnosed properly as chronic pancreatitis. There are difficulty in diagnosing chronic pancreatitis, you will agree.
Right.
Yes, maybe patient develops one acute episode and I had to stop. We had to stop all drugs, whatever he was taking. When he was developing pancreatitis, I had to switch to insulin for control of diabetes besides giving us treatment for pancreatitis. In fact, the literature doesn't suggest any excess occurrence of pancreatitis with any of the DP4 inhibitors. Now we have very large data with with Sita, with Vilda, with Lina. Now data is used. Lakhs of patients have been receiving this. So had it been that concern, I think at least post-marketing surveillance would have brought it out. But maybe hardly any. So as far as safety regarding pancreatitis is concerned, I think it is fairly safe from that angle.
Correct. Dr. Ashutosh has something to add?
Yeah, directly I would say, sir, I have not seen a patient who has been given DPP-4 inhibitor and presented to us with pancreatitis. So I would not be correlating direct side effect of this DPP-4 leading to the pancreatitis. Although many of the diabetic patients are already at increased risk of pancreatitis, and sometimes you are not able to find the reason for pancreatitis. There is no history of alcoholism, no gallbladder stone, nothing, no hypertriglyceridemia. Hypertriglyceridemia is sometimes being missed even by the gastroenterologist. I have many of the patients who are coming with repeated recurrent pancreatitis, and later on they are found to have hypertriglyceridemia. Now that could be a secondary manifestation of uncontrolled diabetes also, or even a primary hypertriglyceridemia. This is the one thing which we have to look for. As such, I would say after starting DPP-4 inhibitor, I have seen no direct case regarding this thing.
So many times now, previously we used to be taught that if it is thin, lean patient, use sulfonylurea. If it is obese or increased weight of the patient, use metformin. That was the teaching earlier when we were undergraduate and postgraduate students. But now the things have totally changed. But
yes,
I still, and I keep telling my juniors also that metformin remains the first OHA to be used in all patients of type 2 diabetes mellitus. And then if you have to add another drug, which I think again we need to reinforce amongst the clinicians also, that you need not wait for a long time and use a second drug as early as possible, especially patients who have a HbA1c of more than 7.5 or so. Probably up to 7, maybe we may use single drug, but beyond 7, I think we need to add another drug. And when it comes to adding a drug, we can again go back to the weight of the patient. Because if it is an early diagnosis, patient is middle-aged, and we are not expecting any comorbidities, then if it is underweight, sulfonylurea still remain good drugs because they are, you see, drugs with a very good action. Only thing is you have to use them more cautiously than you can use DPP-4 inhibitors or so. So if it is underweight, you may use sulfonylurea. If it is a normal weight, DPP-4 inhibitors who are weight neutral can be used. And if it is obese or overweight, you can use SGLT2 inhibitors. That's a rough guide to using a second line drug when it comes to OHAs, because nobody wants to use insulin as a second line drug. So this is what I keep telling my juniors also, that if you find the patient is little fresh, recently diagnosed, HbA1c is more than 7 after giving metformin, then you can be guided by the weight of the patient also. And all those patients who are normal weight type 2 diabetes mellitus, I think you can even use DPP-4 inhibitors in preference to other drugs. What is your take on this, Dr. Ashutosh?
So definitely, like in our post-graduation, when we have this metformin and we have this glimepiride and we have glipizide. At that time, similarly, we were taught that in obese patient, metformin is the first choice of drug, and in a lean patient, sulfonylurea should be used. But now we are using metformin in every patient. So it is not weight-based. Metformin has to be used in all the patients.
Right.
Now, regarding the using sulfonylurea in a thin build patient, it's I would say that nowadays we are not following the same thing, because again, you see DPP-4 inhibitor, if you want to achieve a HbA1c reduction of around 0.5%, patient HbA1c is 7.5, patient is already on metformin 1500 mg or 2000 mg, and still the HbA1c is 0.5 higher as compared to the target value. Still in those even thin build patient, DPP-4 inhibitor would work, because see, incretin defect is there in a type 2 diabetic patient. And if we are giving DPP-4 inhibitor, so in somehow we are increasing the incretin pathway, and we are facilitating the insulin release, because that DPP-4 also increases the insulin release in an indirect way. So
Yeah,
I would say DPP-4 inhibitor.
DPP-4 inhibitors are basically secretagogues, but meal-related secretagogues.
Yeah.
That's the advantage over sulfonylureas.
Yeah. So I would say using a DPP, definitely if the patient HbA1c is coming around 8.5, 9% or beyond that, so you should be using the low dose of sulfonylurea. Even in a thin build patient who is a recently detected diabetic, a low dose of sulfonylurea would work very well. So nowadays, I think low dose of sulfonylurea is a good concept. In many of my patients, I am using glimepiride 0.5 mg. In combination with metformin, in combination with DPP-4 inhibitor, in combination with SGLT2 inhibitor, if like after using 3 drugs, I still add a low dose of sulfonylurea. So sulfonylurea always on my side is a last priority, and I try to start with a low dose and give DPP-4, metformin or SGLT2 inhibitor before, unless finances is a major issue. Now that could also be solved by, because we have this vildagliptin in the market available at a lower cost. We have dapagliflozin available at the lower cost. So like, it's not like that now we are using sulfonylurea much more. We have other category of drugs, and sulfonylurea, pioglitazone, I would say as a third or fourth line agent we are still using. But low dose sulfonylurea I always prefer.
Right. So, Dr. Sumit, where would you prefer vildagliptin over a SGLT2 inhibitor as a second line drug if the patient is not controlling his blood sugar despite giving metformin?
So it depends upon patient to patient. Definitely, in those scenarios, I definitely put your point across. If patient is obese and a cardiac, I would want to, multi-speciality cardiac patients, I would want to use SGLT2. where he can have a reduction and a cardiac benefit of SGLT2 over DPP4. So that we choose according to patient. Definitely in some patient, I would want to prefer and start a patient who's going, an outstation patient or a patient from outside country where he doesn't want to, they don't understand and how to go about the complications. So I would want to start those patients on DPP4. In some patient who's a cardiac patients and obese patient, I would want to put SGLT2. So over a period of time, yes, SGLT2 has taken over so many medications, even insulin also. So our preference is also these days going toward SGLT2 than DPP4, but then that all depends upon patient to patient. I would still, recent studies which has been showing a cardioprotective even in patients who definitely doesn't have any cardiac disease on echo basis, where we have done the studies, have shown, diastolic relaxation abnormalities. So all those things coming into part, I think SGLT2 is taking over DPP4. But yes, we do use both, or we use one over the other depending upon patient to patients.
Right. Dr. Anil, what is your take on using vildagliptin in patients who are elderly or patients who have already CKD?
No.
Dr. Gupta?
Yeah. In patients who are elderly, our main concern are prevention of hypoglycemia. It's a very important concern. And secondly, not to create instability in the patient's cardiovascular system. Two things are very important because they are liable to falls, and fall they may sustain fracture and have all problems. So prevention of fall is our primary goal, as well as prevention of hypoglycemia. Many of the elderly are not looked after well because there are very few people to look after them in the family. So any drug which prevents hypoglycemia, any drug which does not changes the cardiovascular status very much is always preferred. And DPP4 inhibitor fits the bill very well in this situation. So we need not control the glycemia to very rigorous level in elderly individual having a limited lifespan. So that becomes a little less of a criteria. And seeing the social support, seeing the other things, I think DPP4 inhibitors, particularly vildagliptin, can fit the bill and will be very well suited to this particular group of patients.
You're right. And about the CKD?
Regarding CKD is also a very important issue. In CKD, patient is already on multiple drugs. A patient of general CKD takes at least 10 drugs, 12 drugs. Already adding too much burden of other drugs will be not that okay for the patient. So in these patients, simple treatment is always preferred. Vildagliptin, in modified doses, in mild, you modify dose, moderate to severe CKD, you modify the dose to half, and that works very well. And that reduces the dose of insulin. Insulin is the main thing that is being used in CKD. If we can reduce the dose of insulin, we can reduce hypoglycemia, we can reduce other complications related to insulin use by just addition of vildagliptin. So a very good niche for vildagliptin in patient of CKD is there.
Right. Thank you. Thank you so much. If I need to summarize, I think I'd like to highlight few points. One is that we need to add vildagliptin early on in the disease management, not wait for the disease to go out of control and have HbA1c of 9 and 10. So anything more than 7.5 is an indication that metformin needs support, and we need to add another drug. And vildagliptin, since we have been using vilda and sita for a long time, and vilda, because it has gone off patent and the costs have reduced, so I think now it has an edge over sita also, and we can use vildagliptin in more and more of our patients because we have all used these drugs. They are absolutely safe. I don't think we have seen any major side effects with DPP4 inhibitors, and since they are weight neutral, when you compare with the sulfonylureas, and as Dr. Ashutosh also rightly pointed out that since the cost has come down, because with sulfonylureas the main advantage was the cost. But now the cost of vildagliptin has also come down. So we have to use more and more usage of vildagliptin as the first choice of DPP4 inhibitors in near future. Thank you so much, all the panelists, for your expert comments. And I must thank Alkem for letting me talk to Dr. Anil Gupta, an old colleague of mine. We've been together in Maulana for a very long time. Thank you so much. May I hand it over to
Yes,
Mr. Upadhyay Mr.
Yeah,
Jain.
yes. Yeah, thank you. Sir, just related to the same topic, vildagliptin, I'll just take you through one slide and then followed by one very important platform, which is, in context to current situation, sir. Please allow me, sir. I would like to share my screen. Yes, thank you.
Please go ahead.
Yeah, thank you very much. Yeah, I think my sheet, this is visible, sir, to all of you. Yeah. So, sir, I just would like to take this opportunity to introduce first time in the world once daily vildagliptin from Alkem. In the management of diabetes, we have Glovilda OD, which is 100 milligram sustained release tablet of vildagliptin for good control in diabetes. The point of touching the brand is that we have two unique points to highlight here, sir. One is the bicovalent to the innovator brand, which is now given 50 mg BID, and this is a OD dosage, sir. Second unique point is that 84% DPP4 inhibition over 24 hours with vildagliptin sustained release form, which is at par with the innovator brand, which is 50 mg BID. And also would like to share, which is other than this slide, the cost for Glovilda OD is just 10 rupees only per tablet, and as compared to others wherein they have 14 or 15 rupees also, 4-5 rupees, less, per day therapy is there. And now, other thing I just wanted to share with you, we have the unique, Connect to Clinic end-to-end comprehensive teleconsultation, which is from Alkem only. We have got unique features, sir, for this portal, which is free of cost for all the doctors for all specialties throughout the lifetime, sir. Like we have credential-based login by doctors. Platform now allows doctors to create. Sir, just hold on, sir. Yeah, Arun. Eh? Oh. Sir, am I audible, sir?
Yeah, you are audible.
Yes.
Yes, yes.
You are audible.
Right, so nice of you. Thank you. My colleague called me कि yes, कि close हो गया, आपका आवाज नहीं आ रहा. So that's why I was worried. Anyway, yeah. So we have said that this credential-based login by doctor, sir, wherein this platform now allows doctors to create their password to log in platform, and this password there is no need to then every time you put the OTP, sir. What this is one-time password. And then patient bulk upload. Doctor can upload the patient details in C2C platform by patient. There is a tab. Very easy to do this. पूरा Excel sheet आप upload कर सकते हैं इसमें, so that your patient can connect to you through your unique link, sir. And then you can also share prescription through email and SMS as well. मतलब प्लेटफॉर्म में आप कंसल्टेशन दे रहे हैं, बट प्रिस्क्रिप्शन आप SMS से भी और ईमेल के थ्रू भी शेयर कर सकते हैं पेशेंट के साथ में. Then we have one provision of adding of alternate number by doctors. मतलब you can add upon like consultation में ऐसा number add कर सकते हैं so that you are not bothered by repeated calls by the patient, sir. मतलब you some emergency kind of numbers you can add in. Then other than this, there are some more unique features like instant consultation, just like WhatsApp calling, immediately patient without booking any slots can consult to you after paying the consultation fees. There is a three-way AB consultation, sir, wherein a patient caregiver can share the consultation link to the patient, and caregiver and patient can join the consultation with the doctor. And there is C2C Med update, wherein some 14,000 journals, national, international journals are also there in this, which is full text articles are there, which is at no extra cost for any doctor, sir. And then patient education module, wherein you can share a lot of patient education material with the patient related to diabetes or related to your field of practice, sir. And then role creation option for staff to make edit booking. Your staff can also work on this platform in behalf of you, so that you also save your time, sir. And there is a physical consultation can do in clinic physical consultation. So this is about Connect to Clinic platform, sir. And this is from Alkem. So our colleagues are there at the marketplace. Anytime they will meet you, they can share with you, sir, in detail, sir. And not taking much time, sir, I just would like to express my sincere thanks to Dr. Prem Kapoor for moderating the panel discussion, and all the panelists for sharing their views on vildagliptin. And we would also like to thank all the doctors who have joined us today for this panel discussion program. And I'm sure you will appreciate the views on vildagliptin presented today. And we salute our doctors, sir, paramedics who have contributed immensely in current scenario for keeping us all safe and healthy in these challenging times. And we at Alkem, sir, always would love to serve doctors and patients by making our product available, especially our new product like Glovilda M or Jupirose and Alkem. With this, sir, thank you very much once again, sir, and for giving a valuable time, sir. Nice to meet you, all, sir. Thank you very much. Right, बहुत बहुत धन्यवाद.
Thank you.
Thank you. Thank you.
और सब ठीक ठाक, सब कुछ सबका हमारे चले गए.
हाँ, चले गए सर.
डॉक्टर प्रियंकापुर गए. ओके.
हाँ, वो प्रेमपुर चले गए. लिंक
कोई ऑडियंस नहीं ऐड किए हुए थे
सर. ऑडियंस का लिंक अलग होता है, वो दिखाई नहीं देते.
अच्छा. कितना?
हाँ, उनका सेपरेट लिंक है, क्योंकि मैं अभी मेरे कलीग ऑडियंस लिंक में गए और उन्होंने देखा सबका आ रहा, साफ सही आ रहा, नहीं आ रहा, तो ऑडियंस लिंक अलग है. उनकी लिस्ट हमारे पास आ जाती है बाद में.
क्वेश्चन वाला नहीं पूछे उन्होंने क्वेश्चन.
वो क्वेश्चंस का ऑब्जेक्ट, क्वेश्चंस का रखा नहीं इसमें. वैसे हम पहले करते थे, तो इस बार क्या है, हमने वो बिल्कुल फिक्स्ड रखा, क्योंकि टाइम क्या है ना, वो कभी कभी 20 मिनट 25 मिनट ऊपर चले जाता है. फिर वो तो डॉक्टर्स के पास मतलब 40-45 मिनट तो निकाल लेते हैं, लेकिन सवा घंटा 1.5 घंटा नहीं निकाल पाते.
नहीं, जैसे अभी टाइम बचा था ना, अभी तो शायद 10-15 मिनट बचे हुए.
हाँ, बचे थे. अभी तो मतलब 1 घंटे का स्लॉट तो था हमारा. हाँ,
1 घंटे से पहले खत्म हो गया.
हाँ, पहले खत्म हुआ. थोड़ा
10-15 मिनट थे हमारे पास.
हाँ, बिल्कुल थे. और अभी इन केस सर सम क्वेश्चंस व्हिच विल कम टू अस ना, बैकअप में आता है, तो देन वी अप्रोच आल्सो, मतलब जैसे भी लगेगा.
नहीं, अभी तो नहीं है ना कोई क्वेश्चन तुम्हारे पास?
हाँ, अभी तो नहीं सर, अभी तो नहीं.
अच्छा, अगर बाय चांस हो तो बता दो, दे देंगे जवाब.
क्या बात है. सो नाइस. थैंक यू.
चलो ठीक है. ओके.
ठीक है सर. ओके सर, फिर मिलता हूँ सर आपसे. थैंक यू वेरी मच.
थैंक यू.